hopefully.
Please.
Okay, sir. Bismillahirrahmanirrahim. Assalamu alaikum and good day, ladies and gentlemen. I'm Hazima Mozam and I welcome you all to ComStech webinar series. We are very fortunate and honored to have President of the World Academy of Sciences, Professor Dr. Quarraisha Abdool Karim for this webinar. And the title of our talk today is Building Resilient Research Institutions to Undertake Impactful Science, Experiences from South Africa. On behalf of ComStech and myself, I welcome Professor Dr. Karim for this webinar, and to formally introduce and welcome our guest speaker, I would request His Excellency Professor Dr. Muhammad Iqbal Chaudhry. Over to you, sir.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuhu. Good morning, good afternoon, and good evening. We have several hundred people registered for this extremely popular lecture, one of the most important lectures in recent history of ComStech. And we are truly grateful to Professor Dr. Quarraisha for sparing time for this important engagement. And we're looking forward to have her with us in Islamabad so we can have more people benefiting and meeting her in person. So I am so absolutely lucky that I've been working with her as the regional vice president of TWAS, the World Academy of Sciences, and that her leadership is unparalleled. Truly, she had really made a huge difference in TWAS working, its impact, and so many of initiatives. Professor Dr. Quarraisha Abdool Karim is a fellow of Royal Society, which is a great honor for all of us that we have Dr. Quarraisha as a member of the most prestigious society. She is from South Africa, as we all know, and her discipline is largely in the area of infectious diseases, epidemiology. She has been the co-founder of Center for AIDS Program for Research in South Africa, where she is the John C. Martin Chair in Global Health and Associate Scientific Advisor. She's a professor of clinical epidemiology at Columbia University, USA, and Pro-Vice Chancellor in Health Sciences at the University of KwaZulu Natal. She's the president of the World Academy of Sciences, which is the most prestigious academy in terms of outreach and global impact. She also worked with UN AIDS Special Program as a special ambassador for adolescent and HIV related health issues. She chairs FAR Scientific Advisory Board and serves on the boards of Global Health Innovative Technology Fund and the US Friends of Global Fight Against AIDS, tuberculosis and malaria, which are extremely important, neglected tropical diseases in the developing world. She's a member of steering committee of the World Science Forum, Science and Technology for Society Forum, and Forum on Big Data and Sustainable Development, as well as WHO Executive Group for the COVID-19 Solidarity Therapeutics and Vaccine Trials and Ebola Vaccine Trial. Professor Abdool Karim research has been focusing on HIV and TB that spans nearly 3 decades, has impacted policy nationally and globally, and that we have seen how their work has helped shaping many of the policies both in South Africa and other African countries. She had over 300 peer-reviewed publications in leading journals, including Science, Nature, the New England Journal of Medicine, and the Lancet, and she had co-edited key reference books such as Oxford Textbook of Global Public Health and HIV in South Africa. Through the Columbia University Southern African Fugati AIDS International Training and Research Program, she has played a pivotal role in strengthening South Africa's science base by training over 600 researches in HIV and TB. She has been actively engaged in training, capacity building, and mentorship of next generation of science leaders as one of her very important mission of life. She is an elected member of U.S. National Academy of Medicine, American Academy of Arts and Science, and a fellow of Royal Society. The International Science Council, the Chinese Academy of Sciences, Center for Big Data and AI, CBAS, the African Academy of Sciences, the Royal Society of South Africa, and the Academy of Sciences of South Africa. She has received several honorary doctorates from South African and international universities. She has been inducted to Order of something very difficult name, South Africa highest national honor. Her contributions have been recognized with more than 30 major awards, including UNESCO L'Oreal Award, the Canada Gardner Global Health Award, and Noguchi Africa Award, Virchow Prize, and Lasker Bloomberg Public Health Services. The topic is just so extremely important. Of course, she has framed it in the context of South Africa, but it is really important in the context of every region uh, and every country, big or small. And this is the reason that we have uh, so much interest in her presentation. And I'm sure that we would all benefit from what she would present. I have the honor of inviting Professor Dr. Quarraisha for her presentation. Thank you very much.
Thank you very much, Professor Chowdhury, for that very lovely, warm introduction. And it's a real honor and privilege to have this opportunity to address you all this afternoon. I think a time difference between Durban, South Africa, and Pakistan, and it's wonderful looking at the participant list to see participants from different parts of the world joining us today. So, Assalamu alaikum. Thank you very much, Professor Chowdhury and Kasima, for the opportunity to share with you some of my thoughts on building resilient institutions to undertake impactful science and our experiences from South Africa. As Professor Chowdhury mentioned, I'm the co-founder of the Center for AIDS Program of Research in South Africa. And I'm using that to say, when I use we, I'm using the royal we to refer to the other co-founder, which is my husband, Salim Abdool Karim, and also many research collaborators and partners that we have, and the large study teams. And I hope over the next 40 minutes or so to share some of the details around who the we are that forms the Center for the AIDS Program of Research in South Africa and the knowledge generation from this particular institution. So we gather at a critical time where we face multiple challenges. I'm going to focus most of my talk on three pandemics, HIV, TB, and COVID-19, and then end with some thoughts in terms of lessons learned and where we are. So I just want to check that you can see my screen, you can see the slides, and you can hear me clearly.
Perfectly well. Everything is very clear, loud and clear. Slides are also visible. Thank you.
Wonderful. Thank you very much, Professor Chowdhury. So we are meeting at a time where we're seeing a convergence of multiple crises. And I want to contextualize my talk against one hopeful and optimistic framework we have, which is the Sustainable Development Goals, and where member states to the United Nations have committed to it. And we have 2030 as an important milestone. What can we do? And in the midst of many challenges facing us, I want to focus on pandemics and infodemics. And just a quick reminder that while historically we've thought about infectious diseases as something happening in the global south and where industrialized countries have moved on, I think the COVID-19 pandemics have reminded us that challenges, and particularly infectious diseases challenges, outbreaks, epidemics, can very quickly escalate to pandemics that impact the entire world. I also, when we think about science and the hope science brings, that we have a parallel pandemic of mis and disinformation, and where anything is going and the blurring of truth and evidence by misinformation that's not necessarily accurate. We're also seeing a political opinion impacting what is being shared very widely, very quickly with the public, with minimal fact-checking, with no quality assurance that has typically underpinned knowledge generation and the peer review process that we have. Also, a lot of the stuff that's getting into the public domain is anonymous, and we can also see how people are utilizing it to cause divisions and use it in interesting ways that makes our quest for sharing factually correct information, for evidence-based decision-making even more important. And I thought just to say that the real optimism that comes from science is its forward-lookingness, that we like to generate impactful science that unites rather than divides, and that even in shifting and volatile and fluid geopolitics, we have the opportunity as scientists to work together to bridge gaps, even when political relationships are strained. And I'll come back to that. So I'm going to move on now to some of the lessons that we've learned. Sub-Saharan Africa bears a disproportionate burden of the global AIDS epidemic. And when we think about 25 years ago, where we were in our HIV response, when we had the first cases being reported, actually, we knew very little. We did not know what the causative organism was. What we did see was young people dying, and large numbers in industrialized countries, mainly men who have sex with men and injecting drug users. And in Africa, what we're seeing is a disease of wasting. And in all of the epidemics, wherever you were in the world, what we are seeing was young people being impacted at the prime of their lives, socially and economically, between the ages of about 15 to 40 years. And then in 1983, we had Professor Francois Barré-Sinoussi, who was able to isolate the virus as the causative organism. We had already a year later Professor Bob Gallo developing diagnostic assays that enabled us to test individuals, know who's infected, who's not infected in terms of antibody responses. And this combination of knowing the causative organism, having diagnostic tests to identify individuals living with HIV, really enabled us then to move forward in terms of pathogenesis studies, in terms of developing antiretroviral treatment for AIDS, and also to develop options for preventing HIV infections. And I think the pivotal moment was in 1996, where David Ho shared with the world the combination of 3 antiretroviral drugs that changed the face of AIDS, particularly in industrialized countries, from a fatal condition to one that is chronic and manageable. But the big challenge was that these life-saving medication was only available to those who could afford to purchase this, and the price was very high. It made it unaffordable for thousands of people living in the global south, particularly in sub-Saharan Africa. And what we continue to see, even in the face of this life-saving medication, was the drop in life expectancy by about 20 years, and millions of children losing one or both parents and being orphaned, and then the substantial impact on lives and livelihoods, particularly in sub-Saharan Africa. In 2000, for the first time, the International AIDS Conference was held in the city of my birth, Durban, South Africa. This 13th International AIDS Conference theme, Breaking the Silence, really set the stage for a precedent in the history of medicine and in terms of establishing global solidarity, where we had the Global Fund for AIDS, TB, and Malaria established, and we saw drug prices drop, and specifically highlighting the US Presidential Emergency Program for AIDS relief. But this type of global solidarity was not accidental. It took a lot of, it took the convergence of activism with catalyzing solid and good science, and then bringing a whole of society approach where for the first time we're seeing governments, civil society, scientists, industry coming together and saying that what we are going to do is commit to changing the face of AIDS for everyone, everywhere. And there's a little picture that you see here. There's a picture you see here of a little child called Kosi Johnson, who spoke up about living with HIV and made a very powerful story, a very compelling and important message around what it meant to be living with HIV in Africa. What's also important in this moment is how President Mbeki, who was our second elected president, was actually questioning and challenging, does HIV cause AIDS? Now I want to go to the global solidarity and show how with PEPFAR, with the Global Fund for AIDS, TB, and Malaria, we have seen antiretroviral treatment access increase. And you can see from 2010, where we had about 7.5 million people living with HIV accessing treatment, to this exponential increase by 2024 of about 32 million people living with HIV and on life-saving medication. But the evidence in terms of putting people on treatment and then looking at the impact on primary prevention is very different. So we have 1.3 million new infections in 2024, where our target was 500,000, telling us that we're about 3 times more new infections continuing to occur. So if we have to look at the global pandemic today, in 2024, we have about 41 million people living with HIV. And despite this massive increase in treatment access, we still continue to see about 630,000 deaths taking place. And then this 1.3 million new infections. Another way to look at that is about 3,500 new infections each day. About half of those continue to be in sub-Saharan Africa, and 2 out of 3 infections are in young women between the ages of 15 to 24. So why do we have these new rates of new infections? What's contributing to it? And the 3 big challenges that we face. The first is the high rates of infection in Eastern and Europe and Central Asia. The second is in young men who have sex with men in different parts of the world. And then in sub-Saharan Africa, it's really about high rates of infection in adolescent girls and young women. And I'm going to focus on that given my work and our work in sub-Saharan Africa and particularly in young women. So in addition to the 13th International AIDS Conference being hosted in Durban in 2000, we also saw the birth of the Center for the AIDS Program of Research. And this is about partnerships and collaborations based on mutual respect, trust, and synergy, and how 5 institutions came together: the University of KwaZulu-Natal, the University of Cape Town, the University of Western Cape, the National Institutes for Communicable Diseases at the University of Witwatersrand, and Columbia University. And these 5 institutions are really the anchor of the Center for the AIDS Program of Research in South Africa. One of the important issues we wanted to change was where the low middle income countries, the global south, tend to imbibe knowledge generated in the industrialized countries. We wanted to say that there are some unique problems in the global south, and if scientists in the global south do not shift and change being imbibers of knowledge produced elsewhere to actually generating and leading knowledge for the challenges that face us in our countries, in our settings, then we're going to be behind in terms of benefiting from innovation for changing people's lives. So COMSTECH was set up with the goal of undertaking globally relevant but locally responsive research that contributes to understanding HIV pathogenesis, prevention and epidemiology, as well as TB HIV treatment. We currently are the host of a Department of Science and Innovation National Research Foundation Center of Excellence in HIV Prevention. We also host an extramural program for the statutory biomedical research institution in South Africa, the South African Medical Research Council, that works very closely with the Ministry of Health. And here we host the HIV-TB pathogenesis and treatment research unit. In addition, we are the UNAIDS Collaborating Center for HIV Research and Policy. And we also, more recently, one of the centers of excellence for the Global Virus Network. And here it builds on our contributions to pandemic responses emanating from our contributions in during COVID. So just to give you some idea, the COMSTECH team profile, we have at any given time about 250 staff. These include 15 professors, 9 associate professors, 45 PhD scientists, 36 medical doctors, 10 of whom also have PhDs. We have about 12 pharmacists, and we have just a racial background there to show how we reflect the demographic profile in South Africa. But very important is that 80% of the study teams in South Africa are women-led, and we have about 20% males in this study team. Just to tell you, it's not just about women implementing, but the leadership, for example, our executive team has 4 members. 3 out of the 4 are women. And so when you go through to other departments and heads, almost all are women-headed, including our stats department. And it's only a handful of departments, including IT and the pool of drivers, where we have more men than we have women. So I want to move straight away to look at some of the impact we are having globally. And here, for example, when the goal of ending AIDS as a public health was set at a UN high-level meeting in New York, called by the then Secretary General Ban Ki-moon, Professor Slim Abdool Karim and I were requested to have a pre-meeting that would generate the scientific evidence that was used for the 2016 Declaration for Ending AIDS. And you see a picture here of us in the main meeting, and then another picture with the Professors Fauci and Diane Havler, and then Executive Director for UNAIDS, Michelle Sirabi, at the satellite meeting that generated the evidence that underpinned this declaration adopted by member states. On an ongoing basis, we have been part of the scientific expert panel and special advisors to two of the UNAIDS executive directors, starting in 2013 with Dr. Michelle Sirabi. I have more recently, when Dr. Winnie Byanyima was appointed as UNAIDS executive director, she had me co-chairing the committee providing science advice and leading the current strategic plan for UNAIDS. We've also chaired and hosted meetings, for example, following the declaration of ending AIDS as a public health threat. We convened the meeting with many key people in terms of defining what those measurements would look like and how we'd know that we are on track. In addition, we support WHO with science advice, chairing a number of committees, including the Sexual Reproductive Health Group, committees on HIV, and being members of the WHO Science Council. A number of us from Quarraisha have contributed to several WHO ARV guidelines, TB guidelines, COVID-19 guidelines. You heard in the introduction, for example, I'm an executive member of the WHO Solidarity Platforms, both for vaccine development and also for HIV. More recently, I was part of the UN Secretary General's 10-member group that guides the UN in terms of accelerating progress using science, technology, and innovation for meeting the Sustainable Development Goals. There's an annual STI forum hosted in New York, and I co-chaired and co-organized the 2022 and 2023, the 7th and 8th UN Technology Fora. So I'm going to go now to show that if you want to play a role in impacting policy at that level, how do you get to do that? And now I'm going to go through some very specific examples in terms of the type of science underway in Quarraisha and how we've been making a difference. And I'm going to start with HIV and TB, pre-antiretrovirals becoming available. About 70% of our AIDS patients with active TB as the most common opportunistic infection when you have advancing HIV disease. And there are a number of issues in terms of how you treat TB and how you would initiate antiretroviral treatment. And the long and short of it was that here we were preparing to roll out antiretroviral treatment, and the people who would benefit most would be those who had TB co-infection. And at this point in time, we did not know which should be treated first. Should we treat TB or should we treat HIV? Well, the study that we did to establish the timing of the initiation of antiretroviral treatment in HIV TB co-infected patients, published in the New England Journal of Medicine, demonstrated a 56% reduction in deaths from HIV TB, which got translated within days to a rapid advice from WHO. It came back to South Africa, where the then President announced the integration of TB and HIV services. And in South Africa alone, what we've seen is a 52% reduction in annual TB deaths since we released the SAPA trial results. And anywhere in the world you go today and you have a patient with HIV and TB, that management protocol and guideline that's there emanates from key contributions from this trial made by Quarraisha on the timing of antiretroviral treatment in HIV-TB co-infected patients. Now I'm going to move to the prevention of HIV infection in young women, why it's a high priority. In 1990, shortly after completing my master's at Columbia University and starting to do research in South Africa, I undertook one of the first and earliest population-based surveys to try and quantify the HIV epidemic. And what we found was that South Africa at that stage was at a very early stage of the epidemic. The overall prevalence was less than 1%. But what the age and sex disaggregated analysis showed us was up to age 10 to 14, if you follow the red and the blue lines, there was very little difference between HIV in young women versus young men. But when you go to age 15 to 19, you see HIV infection in young women as depicted in the red line already about 6% more than the male peers in that age group. And you see that peaking in young women at the age 20 to 24. And then we start to see infection in men aged 20 to 24, peaking around 25 to 29. And both in men and women, we continue to see HIV across the life cycle. And subsequent data, and now we know this unique characteristic of young women acquiring infection 15 to 24 years, about 8 to 7 years before their male peers, is what's really driving epidemics in sub-Saharan Africa. Despite high prevalence, you see that particularly well here in Southern and Eastern Africa. And it continues to be a key driver of new infections. And while we demonstrated this epidemiologically, I wanted to share with you, this is data from high schools. This is kids in high schools and in the first 2 years of high school. And what you see, this is more recent data the study done in 2010, is that if you look at the prevalence of HIV in young boys in school, it remains rare. But what you see in young girls already by age 15, a prevalence of 2.6%, you see that doubling by age 17. By age 20, about 1 in 10 girls infected with HIV. And by age 20, you're looking at 1 in 4 women infected with HIV. This is, again, more recent data from a population-based survey. And you see this picture, again, red infection in women, blue in men. By age 25, every other woman infected with HIV. But by the time they age 30, about 70% prevalence infection. And you're now seeing in men a very rapid catch-up from 1 in 10 infections in 23 to 24-year-olds to by age 34, about 50% of men infected with HIV. So we're talking about an epidemic here in the province where we do our research, where we work in partnership with communities, and overall prevalence in this particular health district, and there's 7 out of the 11 health districts in this province that has this prevalence of over 30%, where you see women having about twice the number of infections compared to men. So we're able to do phylogenetic analysis from sequencing viruses isolated from newly infected individuals. and generates this kind of cycle of transmission schematic that demonstrates how young women under 25 are getting infected from men over 25, and where the mean age difference is about 8.7 years. These men are getting infected from peers, women 25 to 40, and where the age difference between the men over 25 and women over 25 is 1.1 years. So if men over 25 only had sex with women over 25, we would have seen a very different epidemic trajectory in Africa. But the fact that about 40% of these men simultaneously having sex with young women is what's really continuing to drive the incidence rates in these populations, and despite a high prevalence. And you can see here only 1 in 5 men were aware of their HIV status despite widespread HIV testing and treatment efforts. And young women are not necessarily using health services, so may also not know the HIV status. And the bulk of services are being provided to women 25 to 40 years. So when we generated this schematic of the cycle of transmission, we shared that with UNAIDS, and it became integrated into the report that year on getting on the fast track. The UNAIDS communications team did a much better job in terms of making that schematic a much simplified one. And then coming back, what you see in terms of South Africa's National Strategic Plan, which is the one before the current one, this was the #1 priority. The South African Strategic Planning Team improved on the diagram that had been developed by UNAIDS. And here we have it very much part of the global response, and also many countries in Africa adopting this cycle of transmission and rethinking and reframing their responses to HIV. So by now, you have a good sense that HIV in young women 15 to 24 years is a major challenge, and preventing infection is very important. So when we did the survey in 1990 and made that data available and published it in the peer-reviewed literature, the existing prevention options were abstinence, be faithful, male and female condoms. Female condoms came a few years later. And then in 2009, we had the evidence for medical male circumcision. And the question really is, this is age-sex disparate relationships, young women, relationships with older men. This is fundamentally a social challenge of gender power dynamics. And what we were trying to do at that stage was trying to find a technology that could give women, young women, more agency in terms of remaining uninfected until the point where they could make better decisions, etc. And there was a big gap at that point. Industrialized countries in particular were very focused on prevention in men who have sex with men and injecting drug use. There was some work underway in preventing mother-to-child transmission, but this issue of prevention technologies for women was a huge gap. So what followed is captured in terms of where we were at that stage, what we were trying to do. In the blue line, what you're seeing is this from 1990, this very exponential increase in the spread of HIV as we continue to monitor it amongst pregnant women attending and utilizing public sector clinics. And you can see how that goes from less than 1% very rapidly to about 20%, and then stabilizing around 2010 at about 30%. While this was going on, we were trying to develop by testing a number of molecules for prevention of infection in women. And we started off with vaginal contraceptives They were licensed by the FDA, in particular naloxone 9, and study after study for between 1990 and 2004, we just failed, and we got a very nice moniker of experts in failure. And I'm going to come back to this about every time you do research, you don't expect a positive result. We don't know the answer, but how with each failure we learned to do better. And then in around 2003, when we started to provide antiretroviral treatment in the communities we work in, urban, peri-urban, and rural, we came across a drug called tenofovir, which was a very effective therapeutic agent as part of triple therapy. It had a good safety profile. It was rapidly absorbed with a long half-life. And we were able to see good viral suppression. And there was some animal study data that showed that it could prevent HIV infection. So when you have sick patients, they're much more tolerant to side effects, etc. But when we have patients who are otherwise healthy and well, we need to have something that that has few side effects and ensuring that people would use it. So we then had this idea to move from non-specific agents to use of a very HIV-specific agent, tenofovir. And because of the research being done very closely with communities, when we shared with potential beneficiaries what we're thinking about, they said, well, we don't have sex every day. We need something that can be used when we're having sex. So we came up inspired then by the HivNet 012 data, which is a dose of nevirapine at onset of labor, a dose of nevirapine within 72 hours of birth to the infant. And here we looked at the data we had on tenofovir to come up with this BAT24 coitally linked strategy. We shared always, because we're using public sector funding, this proposed study, and some of our peers and colleagues, particularly from industrialized countries, really challenged this study. And this is a paper that was published in Nature saying that HIV trial doomed by design, say critics. We persevered, and in 2010 at the International AIDS Conference in Vienna, we shared the results from the Quarraisha 04 trial, and for the first time we were able to present proof of concept that antiretrovirals used by uninfected individuals can prevent HIV infection. It was published simultaneously in the journal Science, and that year it was ranked as amongst the top 10 scientific breakthroughs by the journal Science and by the journal Lancet as one of the 2 top breakthroughs. It got immense coverage. This is just a handful of frontline coverage of this trial results from the Washington Post, Wall Street Journal. I'm sure it was also in Pakistani newspapers. It definitely was in many parts of Asia and Africa, the front page news for several weeks. We participated in a WHO consultative meeting, and subsequent studies on daily tablets being used superseded the Quarraisha 04 results. And nowadays, there's WHO guidelines that include pre-exposure prophylaxis, tenofovir with some combination of usually emtricitabine as standard of prevention for people at risk of getting infected. It's part of the South African plans and is now widely available as prevention technology in over 100 countries. So we've dealt with our contributions to reducing high death rates. We've dealt with reducing high incidence rates by sharing the transmission dynamics, contributing to continued high rates of new infections, and also the proof of concept of pre-exposure prophylaxis. I'm going to now spend a few minutes about COVID-19. And I think we all woke up with this anthropological rupture and shock. We developed an 8-stage response plan published in the New England Journal of Medicine that was used by many countries that were struggling to figure out what should we be doing in the face of this new threat. In addition, we published papers looking at the impact of things like lockdown on TB, HIV care, and really advocated for continuing services for HIV, TB, maternal child health, sexual reproductive health, and put mitigation measures in place. In partnership with CRISP, an organization led by Tulio de la Vera, we continue to do genomic sequences of SARS-CoV-2, and we're able to report very early on the emergence of variants of concern. This particular paper published around the beta variant, and then we did a range of studies, and one of our collaborations was with FIND, because we had good characterized cohorts of people living with HIV through the various variants of concern waves that were occurring, and made important contributions in terms of validating, enhancing diagnostic assays, including point of care assays, and showing the utility and validity of results as increasing number of variants of concerns emerge. We did a whole range of other studies, again, in partnership with a number of organizations, looking at the what was putting pressure on the emergence of variants of concerns, a number of vaccine trials, etc. And then where also the first one of the first peer-reviewed publications when the Omicron variant arrived, and this is a paper we published in Lancet. For those interested, this was incredibly, it was a paper written within a very incredibly short space of time, literally 4 hours that Slim and I worked on this. It took 1.5 hours to get the peer review comments, another hour to address that, and the same day this particular article went live. And then when the hard copy came out, it made the front cover of the Lancet. And it just shows about being prepared when opportunity strikes, is not when you prepare, but there was such an urgent need to have information on Omicron, and we were able to contribute that. So I wanted to just share with you a few more slides saying that many people when we look at science and knowledge generation, tend to focus on the publications and the impact factor of the journals and patents and so on. We start, and the highest priority is, are we improving health? So what we want to see is, are we changing policy? Are we changing practice? How are we contributing to policy deliberations? Are we changing health practice? Are we changing the research landscape? And are we changing South African stature in science? And then we go to things like citations and so on. So just to flag that framework that we use to evaluate our own work and how we're making a difference. And to say that, Quarraisha scientists, several of us are elected members to prestigious science academies. We have 2 members of the UK Royal Society, several who are members of NAM or NAS, and then several other bodies such as the World Academy of Sciences or national bodies like the Academy of Science of South Africa or a regional body like the African Academy of Sciences. We are also members of boards of several medical journals, and I have a listing here which I won't go through, but includes the New England Journal of Medicine, Lancet, other AIDS-specific journals, and infectious diseases journals. We have, and these statistics, you can only generate it over a period of time, but from our establishment in 2003 to 2022, just now over 1,400 journal articles, 40% of these have COMSTECH scientists as first authors, and a number of these are in high impact journals. Over 200 of our articles have more than 50 citations, about over 100 citations. Our science paper, which describe the proof of concept of pre-exposure prophylaxis, has over 2,000 citations. I want to spend a few minutes on this particular slide, which is for the period 2010 to 2025. And here, if you look at the bottom line, it's an incidence rate of publications in different journals. And there's 2 bars there, which the first is where we do collaborative research and we just co-authors or partners, versus where COMSTECH scientists are first authors. So if you look at the bottom line, this number 5 tells us that we see an article published by a COMSTECH scientist every 5 months. And if we take of the 31 articles, 14 of those where COMSTECH scientists were first authors in that particular contribution. In the journal, in the family of journals of Nature, we publish every 2 months, reflecting the basic science contributions, including in the journal Science, where we have a publication every 6 months, and in journals that are associated with Lancet Global Health, Lancet HIV, we have a publication every month. In our more infectious diseases specific journals, in the Journal of Infectious Diseases, we have a publication every 6 months, in the Journal of Virology every 4 months, and in the Journal AIDS every 3 months. And then you can see in journals with the impact factor greater than 5, about 36% of all our publications are COMSTECH-led authors, and in journals less than 5, 40%, and that just gives you that distribution. In addition to our peer-reviewed publications, we also publish widely in general media, and this is print, you can see in terms of TV, radio, newspapers, online, social media mentions, the distribution of these communications, not only in South Africa, but also in other parts of the world. And you can see the top 3 international countries include Pakistan, and that's the sort of add value from that public science communication. We have a number of patents, and patents is not for me. We believe that knowledge and knowledge generation is a public good, and so it's not to make money, but it's to ensure equitable access of our discoveries across the global South in particular, and it's enabled us to negotiate 2-tier pricing and also affordable prices for some of the things that have moved on. We also get a number of awards and prizes. Over the past 20 years, we've had more than 48 awards And the awards is really about showing that the Global South can produce knowledge that's globally recognized. And I highlighted a couple in recent times: the Lasker Bloomberg Award, Gerdner Award, Noguchi Prize, Virchow Prize, Christophe Meroux, etc., etc., just to give you some indication of the impact that we're having and that scientists from the Global South can have. Just to highlight here, all of our facilities adjoin public health clinics or hospitals, so there's a very rapid translation of our work and ongoing awareness raising, so that it's not when you have a policy that you're going to healthcare workers or governments, and that our knowledge is generated with communities. So they co-own the knowledge we're generating, they co-invest in it. And so when you have something that works, we have high rates of acceptability and persistent use. This is giving you some pictures here on some of our work in deep rural communities, but also pictures of our facilities that are in urban settings, peri-urban settings, and also in deep rural communities where we work. And then just to round off, our real legacy is in terms of the next generation of scientists. And we built this on people, and we continue to build this. This just gives you a profile at any given time. We have about 200 either graduates, postdocs, doctoral students, or master's students. And in the time that we've been at COMSTECH, we've had close to 2,000 trainees at different levels of training with us. I want to thank and acknowledge many people who've contributed to our work, and to also thank our funders and collaborators. And I'm going to stop there because I've used up my time, and I hope that in the Q&A session, we can continue and I can elaborate on some of the points in terms of moving ahead and forward. In terms of contributing knowledge through partnerships, the importance of academic freedom, how we address socioeconomic issues, and build a global ecosystem so that everyone, everywhere can benefit from science. Thank you very much for your attention.
Thank you very much, Professor Dr. Karim, for an excellent and a very comprehensive presentation. With your permission and permission from His Excellency Professor Iqbal, may I read out some questions posted for you in the chat box?
Please.
Please go ahead, Kasima.
Okay, so the very first question is from Mr. Hasifa. She's asking that with the cutoff of the financial support by the US government, many HIV patients can no longer get access to HRVs because they cannot afford it. Isn't this going to hike the number of the new cases and increase the mortality of those formerly on these drugs?
Yeah. Do you want to do a few questions, and then I'll maybe in clusters of 3? Yeah.
Okay,
Thank you.
sure. Okay. So there is also this question which says that, give me a minute. There are so many comments and good questions for you, so I really have to find something very important. Okay, so what are the most effective ways of raising awareness among the youngsters to stop the spread of HIV and TB in the local communities? Are there any low-cost or community-based methods that can help reduce the spread of these diseases? This is the second question. So let me just take another question. So, okay, so this is something that is also very important. I think, what role has the natural products, leading drugs entity research has contributed to the decline of the rate of the viral infections and their management, particularly in context of the low middle income countries? So I think these are 3 questions.
Yeah, wonderful. All 3 excellent questions. So the first question around funding cuts is gives me the opportunity to say that, in life, we have ups and we have downs. And, life is not always about great times. So it's in terms of downs, it's how we respond to that. And I gave you one example of failure. And if we just roll over and die, that's not going to get us anyway. But it's how we build resilience and strength in terms of dealing with adverse points. So in terms of HIV, I want to start by thanking the US government and the US people for their generosity over 2 decades in terms of increasing access to antiretroviral treatment in highest burden countries across the world. Now, some can look at aid as acts of charity or generosity. I think about AIDS as a strategic investment. And it's also about partnerships that are mutually beneficial and synergistic. One of the important issues is that Africa has a very young population. About 65% of our population is under the age of 35. And we contrast that in industrialized countries where we largely have aging populations. Africa also, I did not present a slide, but for those interested, we're seeing, if you look at knowledge generation in the global south versus the north, we are seeing much more rapid growth in terms of knowledge generation. But the funding cuts, the challenge of it was that it was very sudden. So it wasn't a way someone spoke. It was like overnight, the money is gone. Now the money is being reinstated, and there's a whole process underway in terms of transitioning. In South Africa, we have less than 1% of the global population, but have 1 in 5 infected individuals and more new infections taking place. The South African government, a little while ago, took over the purchase of the drugs and making that freely available in the public sector. So I want to use that as an example to say that when you're in a crisis, aid and assistance from external bodies are very important. But we provide health services, all of our countries in the global south, some better than others, free of charge. So I think what happened with the money coming in, many countries decided someone else should take care of this. So if you have people with diabetes, hypertension, you don't go to some other country to look after them. We look after these patients ourselves. So I think this was a nice wake-up call for countries to look at what are they doing for their own citizens, and also how do we make sure that our national budgets cover all of the health challenges that face us? How do we invest more in research? How do we invest more in strengthening our health services? We're all committed to universal healthcare. So to me, these are the issues. There is the more prolonged countries are in making the transition. Yes, we do have the threat that is very real of interruptions in treatment, in the emergence of drug-resistant strains of the virus, and compromising interventions and opportunities that we have. I think during COVID, we saw how vaccine rationing pushed and put pressure on emergence of variants of concern. So it's something for us to all think about as civil society, as governments, as industry, and also an all of society approach, that when we have challenges, how do we shift this mindset from waiting for others to come and solve it to coming up with solutions ourselves? So that was my comment on funding cuts in terms of increasing awareness. And I think that today countries have connectivity, smartphones, QR codes. I'm always amazed when I'm traveling in Asia to see how people don't even use hard currency these days. Everything is being done on the phone. But we also have digital divides in terms of unaffordability. But I do think that one of the things we have in common in low middle income countries is this strength of storytelling and the influence of oral histories and so on. So I'm not going to say, well, to raise awareness, we need to do this. I think that to raise awareness, we need to look at what is the most effective way of communicating with people and to utilize it. And I think the important piece is societal recognition. One of the new challenges we're facing is the growth in substance use, for example, including injecting drug use in addition to sexual transmission. So how do we deal with it? It's very intertwined with organized crime and so on. But as societies, we have to think to our aunties and uncles and who do we normally go to? So some things you can talk to your parents about, some you can talk to healthcare workers. Today we do, how do we teach critical thinking? So what can we extract? And how do we play a bigger role in terms of ensuring reliable information gets out? How do we teach people about interpretation of what's good information, not good information? And I think right now the social media platforms are being used negatively in many of our societies and communities as scientists. And we're all not good science communicators, but I think we all need to learn to communicate better, to partner with people who are able to communicate, to look at influences and others and see how can we get good, reliable information for better health, preventive, promotive health, for treatment, etc. So I think that there are ways we can do that, and it is possible with an all of society approach. So societies as a whole need to recognize this is a problem in our country, in our community, in our district, in our county, or whatever the unit is. And we're really talking about local responses. We now have a pandemic treaty. That pandemic treaty is going to be successful if we can contain outbreaks. So surveillance is important. So we need to take charge of our health. There's a whole new piece around self-care where we're moving in. And how can self-care complement? How can community health workers, and I know Pakistan has good examples of community health workers who are an important bridge between healthcare delivery, formal settings and facilities, and the community and the population. So how do we do that better? How do we use that better? In terms of natural products. So I always like starting with saying that germ theory is very new in our lives. It's only about 150 years. But what's much older is our indigenous knowledge systems. And I think in some of our countries, we have better documentation of our indigenous knowledge systems and better formularies and better validation of indigenous approaches. In many countries, it's still very informal, it's very anecdotal. And I'd say for indigenous knowledge systems, indigenous capabilities and capacities we have is very, very important. We just have to do a better job of documenting and structuring that more systematically, so we don't have, in anything, if you take the atomic bomb, for example, I don't think that was the original intention of its use of the knowledge, but there's dual purpose. And, right now we're seeing wars being fought with digital technologies. That wasn't why, if you speak to Lee Berger or others who created these tools, that was not the intention. But you always have this negative piece that come in. It's the same way if you leave things unregulated, uncontrolled, uncurated, you have these snake oil and charlatans coming in. We also have it against in health professionals. During COVID, we had health professionals promoting ivermectin when there was no evidence that ivermectin, in fact, subsequent evidence showed harm. So we all have to be more mindful. We all have to be more familiar. I think we are beyond the point. If science is our hope and knowledge generation for the betterment of humanity is what's going to move us towards sustainable futures for this and future generations, then we need to make sure that science is not an ivory tower endeavor. It's demystified, it's available, it's accessible. Everybody understands it and can make good decisions about themselves and for their families. Ready, Kazima, for the next round of questions, if we have time.
Thank you very much, madam. Honestly, this session has been so wonderful, but unfortunately, we're running out of time. So, but I would, with permission of Professor Iqbal, we'll also invite you some other time so that we can continue with this, wonderful discussion again, inshallah. And with this, I would request His Excellency, Professor Dr. Iqbal Chaudhry, for his closing remarks. Over to you, sir.
Thank you very much, Professor Quarraisha. It was truly remarkable, wonderful lecture, extremely engaging. I mean, it really covers so many aspects of it. But I would say that there are two important lessons that research can have a huge impact. You know, what we have done has really had impact on policy. It had impact on training, and it triggers a whole range of innovation for the prevention of the disease, not only HIV, but in fact, this has created a model for other diseases to be prevented. So your research is certainly has contributed, and these work are truly remarkable because that laid the foundation of a high quality research, which can be quickly translated at the community level, can have a huge impact. Second is that institution which you represent is just phenomenal. You know, this organic relationship, very high quality scientists working in a very high quality institution, each nurturing each other, strengthening each other, is an extremely important one. And this is exactly what you're trying to do at the platform of TWAS, that creating institution is as important as developing capacity. And I am, on behalf of OIC COMSTECH, which is a ministerial standing committee for science and technology, covering 57 countries, is truly, truly grateful to you for your time. We sincerely hope that you would give us time, that you would visit our secretariat, and also we would like to have you in other kind of member states where we have different activities, that your time would be extremely important. Not only that you represent good quality science, but your personality is truly iconic, inspiring for all of us, particularly women. So thank you very much, and Jazakallah khair. Thank you.
Like very much appreciated the opportunity to be here virtually, and inshallah, I mean, I may see some of you in person in the near future. Thank you once again for the opportunity to address all of you and for your participation.
Thank you very much. Thank you very much, madam. Thank you very much to all the participants who joined us from different corners of the world. Thank you very much, and we hope to see you again in some of another exciting COMSTECH webinar, inshallah. Thank you very much, and bye-bye.
Inshallah.